Today we have with us Dr. Hamid Razak, Consultant Orthopaedic Surgery at Sengkang General Hospital and Associate Professor at Duke NUS Medicine School. An avid sportsman himself, running has always been a passion for him. And on a personal note, having been the first doctor that had
Don't be
actually
rude, okay?
attached myself to for clinical attachment, I'm honored today to be moderating a talk led by him. For a change, Prof, today I'll be asking the questions and you have to give us the answers. Prof Hamid is a leading knee specialist and so knowledgeable yet super humble and well liked by his patients. You can see them coming in for consultation and the first thing they'll ask is how he's doing, how he's coping. So definitely a very well liked man. Today we'll be focusing on a topic that I think a lot of us can actually relate to, the well-being of our knees. Many of our members, we have like knee pain during our runs, after runs, some even with like daily knee pains. So I hope today's talk will help us all understand our knee better and maybe how we can deal with our knee pains. So without further ado, let's invite Prof. Hamid to share with us about extending the COE of your knee. Prof. Hamid, please.
Thanks very much, Komresh, for the very kind introduction. Really a great honor for me to be sharing with you, fellow runners from the TMR family. I'm pretty new to the family, but yet I've seen the love and the how you guys have embraced me has really touched me more days than one. So I'm more than happy to share what I know about a topic that's very close to my heart. It's my bread and butter of my job, obviously, to try to save as many knees as possible from undergoing knee replacement. So that's my personal motto in my professional life. I will not belabor the point. I think Komresh has already introduced me. But just to add that essentially my subspecialty interest lies in this topic, emerging topic called knee preservation. For those who are not very aware what this is about, we have heard of knee replacements. So knee preservation is essentially to say it in a very tongue-in-cheek manner, the antithesis to a knee replacement. Essentially, we're seeing patients younger and younger presenting with knee arthritis. And knee arthritis is having not just a health burden, but a huge economic burden as well, as a lot of young people are in their working time of their lives and takes a lot of time off work when they suffer downtime due to knee issues. So knee preservation essentially deals with procedures or techniques intended to extend the longevity of your biological native knee so that you can keep your own knee for a longer period of time. And the whole basis of that is because a knee replacement has a finite lifetime, right? A good knee replacement can last somewhere between 20-25 years if done well without complications. And even in a well done knee, there is a group of 15% of patients who remain unsatisfied. And it would be a disaster if young patients end up being that 15% despite getting a knee replacement done, which is supposed to help them get back to work. So that's where my research and my clinical interest lie in. And with that disclosure, I'll begin the talk. When we talk about the knee, this is a very common picture that we normally see if you Google knee arthritis, or if you've attended other talks or awareness about knee problem, you will see an X-ray that shows bone-on-bone disease and arthritis of the knee, pretty worn out cartilage in the knee. And that for a long time we have been looking at the knee as a mechanical organ, a mechanical issue, right? Just wear and tear, and therefore you need to go for a knee replacement. I choose to view the knee very differently. I choose to view the knee as actually an organ, just like how we want to prevent heart disease. We treat the heart as an organ and we optimize all our risk factors, right? We try to make sure we have good blood pressure, we ensure that we have our cholesterol levels are good, our weight is kept in check, and that we exercise regularly to get aerobic activity to train your heart, to pump your heart. The knee is very similar. You have to treat the knee as an organ. There are many factors that affect the health of your knee. Not just the fact that it is something that is a mechanical organ that is driving your walking, your running, and gets you from place to place. The knee has cells, the knee has fluid, it has lubrication, it has so many things, as we'll see in the course of the talk today. So this is an unannotated diagram of the knee, showing all the various components of the knee. Don't worry, Komresh, I'm not going to test you on anatomy of the knee, okay? So you have the cartilage as we know it, right? This is essentially the gold in the knee. This is the be all and end all. If you lose cartilage, you're not going to get it back, right? So this is what lines your joint, and this is what provides your lubrication for your daily activities. You also have the meniscus. We'll talk about the meniscus a bit later. These are C-shaped, you can call them like your suspension of the knee, right? They essentially absorb shock in the knee as you walk and you drive impact through the knee. You have your ligaments that confer stability to your knee. It makes the knee stable, prevents it from wobbling around, so that the top bone stays onto the bottom bone as you move. You have obviously the bone. Many people, in fact, ignore the bone. The bone health is actually very important for the knee to function normally. A lot of the pains that we experience in our daily lives can be due to overloading of the bone or underloading of the bone, which gives rise to weakening of your bones such that it cannot support your weight. We have the muscles and the nerves in the muscle that, again, doesn't come at the top of our head when we talk about knee problems. Deconditioned muscles, not just above the knee, but as high up as your hip, because the hip is a joint that is supporting the knee. So your hip muscles, when they are weak, they can give rise to knee pain as well. And not represented in this diagram is what we call the synovium and the synovial fluid. These are medical terms. To mention it very simply, the synovium is like a plastic covering of the knee, right? If you imagine we put a shrink wrap around your knee, that is essentially the synovium. It protects the knee from infection and from things and from entering the knee joint. And it also is a very active biological tissue. The synovium actually produces your fluid, the lubricating fluid, and the cells that help in the recovery, the self-recovery of the knee. So some diseases like rheumatoid arthritis or even psoriasis, and even osteoarthritis, the normal run-of-the-mill wear and tear, can affect the synovium. And what happens is that the synovium, as it ages, it doesn't produce enough synovial fluid. And therefore, we start to hear creaking noises in our joints, or start to develop pain and swelling. So, I've probably set myself up by naming the title Extending the COE of the Knee. So I was thinking high and low yesterday to try to find an analogy, from the automotive industry to try to illustrate some of my points here. So, for order for our car to keep going, you reach your 10-year COE and you want to extend your COE, there are some things that you will look at, to look at the viability or the wisdom of your choice of driving this car for longer. And wheel alignment is very important, obviously, right? That's one thing that we look at. In order to increase the stability of your car, your tire stiffness, especially the outer part of your tire, is very important so that your car, when you drive, is stable. Suspension is important as well to reduce the impact, especially if you are, on undulating terrain and you have a lot of humps and bumps to drive over. You need to have a good suspension. And obviously, you need to ensure that the engine is well lubricated with your engine oil. You need to have water in your radiator to prevent overheating of your engine, and you need to have sufficient fluids for your brake fluids, etc. So we know that these 4 factors are important to keep your car going, right? And I can draw an analogy from these 4 factors to how to keep your knee going, right? The knee also has an alignment, right? It has the stability, the natural stability given by the ligaments. It has the meniscus, as I mentioned previously, which are the shock absorbers and can equate to the suspension of your knee itself. And you have the cartilage, which really is the lubricating oil, or similar to the engine oil in the car. So let's go through one of each of these 4 factors and find out how it contributes to health of the knee as well as disease of the knee. Those 4 factors are not on the same playing field. It's essentially they are arranged, or for me conceptually, they are arranged in a pyramid fashion. And when we talk about food pyramid, we talk about hierarchy of needs and things like that. The most often the most important factor is often at the base, because that actually is your foundation of your pyramid. You get the else goes wrong, right? So alignment is this foundation, right? Your knee needs to have a good alignment for it to function optimally, right? If you want to keep your knee going for a long period of time, you need to have a good alignment. And then you need to have a stable knee. If you have bad alignment, your stability will eventually deteriorate because your ligaments will be stretched beyond their native stiffness. And over time, they will just stretch out and the knee will not be stable anymore. Similarly, if you have a mal-aligned knee and a very unstable knee, your meniscus will be taking a lot more load than usual, right? And these suspension, these shock absorbers have a limit to the amount of load they can take. So if your alignment and stability is off, the next to go will be your meniscus. Your meniscus will tear, and what is left to face the impact of your knee would be your cartilage. So these 4 factors are arranged in a form of a pyramid because when I see my patients, when I assess their knee, this is how I prioritize my needs in terms of assessment and also in terms of treatment. You cannot just treat a cartilage problem on its own when you have a patient has a meniscus tear, an unstable knee, and a very bad alignment. That surgery or that procedure is good as useless, because the cartilage treatment that you're giving the patient will not survive itself, because the patient has a lack of a meniscus, they don't have a stable knee, and they're not aligned well, so that treatment will not last. When we talk about alignment, our body actually undergoes changes as we grow from a young child into adolescence. Many of you are young parents here, and many a times you might be a bit apprehensive. Why does my child have this, walking in an O shape or limping around, as he starts to walk? That's because that's natural for a child, because they have not started putting weight on the leg. That's the native, natural alignment that the leg has. We call it bow-leggedness. You can see the child is 1 year old, and as they progress on to 3, as they start walking, it will assume a rather straight or slightly knock knees, what we call knock knees kind of alignment. And when they're well into their adolescent, it becomes fairly straight. Now, having said that, a lot of us, including athletes, right? Top athletes, top sprinters, we have what we call a spectrum of normality. It doesn't mean that only a straight leg is a normal leg. There are people amongst us with no knee problems at all, with bow-leggedness. There are people amongst us with no knee problem at all, with knock knees as well, which I'll show a bit later. And this is what we call the normal variant. Now, this alignment is not a problem for you, but if you do sustain an injury, you do have if you've gotten a cartilage injury or meniscus problem or a ligament problem, that degree of alignment that you have becomes a factor to consider in your treatment or how your disease may affect you. As long as your knee is healthy, having a alignment that is within this normal spectrum is actually completely fine. So don't be worried if you look at yourself today and you find that, hey, how come my knee looks like the 3-year-old boy or we're still like the 1-year-old boy? That's completely normal, right? That's what we call constitutional alignment. Constitutional because you were born with it, just like our country's constitution. You can't change it. So constitutional alignment cannot be changed, right? So that's what we call. So when we assess alignment, what we are looking at is these 3 points: the hip center, the knee center, and the ankle center. So ideally, it should all form a straight line. Some people have bow-leggedness and some people have knock knees. And if you look at this, if you are bow-legged, you can see if I draw that line from the hip center to the ankle center, it falls within the inner compartment of the knee, what we call the medial joint or the inner part of the knee. And if someone has knock knees, you can see that line falls in the outer part of the knee. Now, what this means is that naturally, when you walk, you're going to be putting more weight, more of your body weight is going to go through that compartment that your alignment passes through. So like I said, if you have a healthy knee, that's not a problem. But imagine if you have a meniscus tear in the inner part of the knee, or imagine if you have a big cartilage ulcer in the outer part of the knee from a basketball or a football injury, then this alignment is going to be a problem for you, because you're going to be putting more of your body weight in the outer part where there is an ulcer. You might get more pain. And if you have a meniscus tear in the inner part of the knee and you have this alignment, what we call bow-leggedness, you're going to be putting more weight through a meniscus that is already torn, and therefore you're going to undergo wear and tear in the inner part of your knee. There's a higher chance of that happening. Next, we move on to stability. Sorry, I forgot to say, ask for any pregnant mothers in this. So I'm going to just quickly skip through. So you can see that, that was a nasty injury, and that's how ligament injuries happen, right? When you have a pivot shift injury, what we call, when you play sports like basketball or football, when you pivot on one leg, when you turn abruptly on one leg, it is non-contact. Usually what happens is that you tear ligaments in the knee, and the knee has several ligaments. The most commonly known ligaments are your ACL and your PCL, what is called the anterior cruciate and the posterior cruciate ligaments that prevent the knee from going in this direction. And then you have your MCL, the medial, the inner one, inner collateral ligament called the medial collateral ligament, otherwise known as the MCL, or the outer collateral ligament, otherwise known as the LCL. And that prevents the knee from going sideways. So these ligaments, work as a 4-bar linkage. You can imagine you have 4 bars in the knee connecting it together, and it prevents the knee from going out of place. And that is very important to keep the knee going for a longer period of time. Next, we talk about meniscus. To draw an analogy, imagine a flat surface and a round mortar coming down and punching on it. When you have something round pressing down on something flat, what is going to happen is that you're going to have one part of this construct that has a very high load or a high stress. This is not a good design for a knee. It may be a great design for an amical, you know, when you grind your turmeric or your chili, you know, in those days our mothers used to do. That's how it is, right? It's a round a structure that they grind on a flat surface to create intense pressure to grind your spices. It's a terrible design for a knee, you can imagine, and that is what God gave us meniscus for. When you put the meniscus on the flat surface, it converts the flat surface of the bottom bone to have a round receptacle, and the top bone, which is a rounded surface, can now gently rest on the bottom bone. And when you walk, this forms a very, what we call a congruent joint. That means it moves with very little friction, right? And that is why the meniscus is so important to prevent wear and tear of your cartilage. So when you do that, when you walk, the stresses don't accumulate at one single point. They are dissipated around, and the cartilage can then breathe easy, and they are used to that kind of a low level of load and low friction. But the moment you tear your meniscus, you lose this integrity, you lose this relationship between the round and the curved surface, and it goes back to the left diagram where you have a round on a flat surface. That one part of the cartilage is going to undergo a lot of stress, and therefore is going to undergo accelerated wear and tear. So this is a MRI diagram. You know, many of you have gone for an MRI will know how the images look like. You can see that, you know, you have your meniscus sandwiched in between the two bones that converts the flat surface of the tibia, the bottom bone, into a rounded contour that can receive the femur, which is the thigh bone. And this is a patient of mine, you know, where you can see there is bone on bone arthritis in the inner part of the knee, and largely it is due to a meniscus tear. You can see that the meniscus this is a photograph taken from inside the joint. It's torn, and you can see there's a huge cartilage wear and tear area just next to the meniscus tear. And you can see the bottom area is also devoid of cartilage. And this is really how arthritis develops after a meniscus tear. Now, I put a picture for those of you who are clued in to the Da Vinci Code, you know, you know, this is the Holy Grail, right? Because the cartilage is treated as the Holy Grail of the knee, because yet till today, we have not found how we can actually regenerate or grow or reverse the damage to cartilage, which is why I emphasize so much on alignment, stability, and meniscus, because I can't do much about the cartilage. Yes, we have some procedures to repair cartilage when they are early stage or when they are just an isolated injury. But for someone who's aging, who has lost cartilage, till date, we do not know how we can actually reverse that process. So you can see, you know, how cartilage problems progress from grade 1, which is just softened cartilage. It usually doesn't give any symptoms. You don't know you have such a condition. It progresses to grade 2, where you have what we call fissuring, just like how you have a little bit of you know, at the end of a cloth when you have thread that is coming off. That sort of a problem in the cartilage. Then it progresses to what we call a stage 3, where you have a partial thickness ulcer. Just like how we have a mouth ulcer, you get ulcers in your cartilage as well, and they can be of partial thickness. You may still not get symptoms at this stage in some people until you go on to stage 4, when it's a full thickness ulcer, when your bones are exposed and then your bone comes into contact with bone, and then you start to get pain. And then what happens is that it's a vicious cycle, because one part of your knee has now less cartilage, the bone hits the bone, your alignment then starts to shift because one area, the bone is collapsing on each other. And that malalignment, what does it do? We spoke about it earlier. It makes you put more weight into that area of the knee, and the knee can't cope, because when more weight comes to it, more cartilage starts to wear off. So you get this vicious cycle until you get end-stage arthritis. So to summarize again, back to the joint preservation hierarchy, as I call it, you know, the 4 things that keep your knee going are essentially your alignment, your stability, the health of your meniscus, and the status of your cartilage. So cartilage being the holy grail. So I'm now going to move on to specifically talking about running and what are the tips, you know, that we as runners have to keep in mind to keep our knee going. You know, this is a very famous quote that many physicians have quoted. So I actually do not know who's the original person who said this, but it is very relevant today as we talk about lifestyle factors. You know, we all say that, oh, it's genetics lah, I can't help it. I got high cholesterol, heart problem. My mother has arthritis, so I'm going to get arthritis. It is true. Your genetics loads the gun, but it's our lifestyle factors and the choices that we make that actually pull the trigger. So we can still yet hope that with lifestyle modification and with certain decisions that we make, the trigger may not be pulled, and we may not be facing the eventuality, so to speak. Okay. So key message for reducing knee problems and to keep the knee going is essentially just these three words: reduce the load, right? It does not necessarily mean run less or run slower, but really to adopt certain healthier techniques of running and to watch certain aspects of the mechanics as we run to reduce the load, even when you do long distance, short distance, sprints, marathons, ultra marathons, Ironman, name it, you can do it. One of the things that is often cited is to shorten your stride. Now, this is the image of my own, my cadence from Garmin Connect, right? And studies have showed that if you increase your step rate of running by 5 to 10%, it actually reduces your joint load by 20%. And this is because at a stride rate of 160 to 180 steps per minute, what happens is that your knee remains in a very semi-flexed position and in a very softened position at that step length, and therefore you reduce the load, especially in the front of your knee, what we call the patellofemoral joint, the kneecap area, right? So this is one very easy way for you to actually reduce the joint load. It is not very easy for those of you who are very used to taking long stride lengths. It takes a while, and you might find yourself that you are or foot strike later, right? Many a times, when you try to do higher strike length, you might transit from non-4-foot strike to doing a lot of 4-foot strike running to catch up for your cadence. You should watch out for that because you may actually get more injury if you are running with a foot strike pattern that you're not used to. Your shoe may not be suitable for that as well. So this is a caveat, but generally speaking, most runners or running coaches agree that a stride rate of 160 to 180 generally decreases the joint load. Next is about the form of running, right? When we, for those of us who go to the gym, we always talk about the form when lifting weights, etc. But actually, there is a form to running as well. And this is a very simple diagram to show what I mean. Essentially, with a proud posture means to have a straight back, so to speak, not to overarch or not to bend over too much, because then the force line will fall far into the front of the knee or far too to the back of the knee, and that may actually affect the wear and tear pattern and characteristic of your knee, and also your muscles may be acting in very weird angles. So this is what is recommended by Runners World, right? Proud posture, straight back, keep your arm close to you, compact arms, don't swing your arms wildly unless you are going for a finishing 100-meter, 200-meter sprint finish. Keep your knee bent when landing is what I talked about of the softening of the knee. When you land, you don't want to land with a hard break. You don't want to fully lock your knee and land on your heel, because that actually increases the load by very, very high, up to 3 times higher loads through your knee. So soft knee bending, and as I mentioned previously, higher cadence, right? And what happens usually is that in order to pick up speed, a lot of us do, we tuck our hips in. We keep our hip adducted, or you strain your adductors, and you, like I said, when you overstride, you may get hamstring issues as well. Next, of course, needless to say, our weight plays a huge role. Um, what our body weight, right? When in a single leg stance, when you are running on one leg, 50% of your body weight goes to that limb, right? And when you are going downhill, about 3 times your body weight actually goes through your kneecap joint. That's a huge amount of force. And many of you may realize that you're starting to develop some pain on going down the stairs, but actually going up the stairs or flat ground walking is completely okay with you, right? So this is the reason why. That's because when you go down, about 2.7 times your body weight actually goes through the knee. So keeping our ideal weight is an important aspect of reducing the load on the knee as well. Shoe management. Hopefully none of us have shoes like that with our toes peeking out. It is generally recommended that we replace our shoes, after 500 to 650 kilometers. Those of you who use, Strava or Garmin, it automatically tracks for you the distance that you have run on your running shoe if you put your apparel inside as well. However, there's no consensus on what shoe is best for reducing knee load. There are a lot of commercial gimmicks out there selling shoes with certain sole patterns that says that you'll be reducing the load on your knee if you use my brand of shoe, but there's no real studies to show that. But it is important to switch shoes after its mileage, and important to take care when switching the new shoes, especially in the initial phase as you break in, because that is a high risk period where you may develop a foot and ankle injury due to not being accustomed to the footwear. Yep, and mixing it up is very important, right? if you run the same route, same distance, same speed every day, you are going to be using the same muscle groups of your lower limb and upper limb every single day, and they're going to get tired, and you're going to wear them out or get injury. So changing the pace, changing the type of running to do tempo running, for example, once a week, and then doing a easy aerobic base run at a reduced pace, and then doing sprints, to mix it up is very important. To have variety in how we run is important because you use different muscles, and at the same time you develop different capacities for your lung, both your anaerobic capacity and your aerobic capacity for your run. Of course, we need that extra push to push your VO2 max sometimes to get your extra fitness if you're aiming to get certain landmarks in your competitions. But otherwise, having a variety, and even sometimes we cross training, going swimming. I see a lot of our brothers and sisters posting swim photos as well, which is great, right? Because you use a different muscle set, and that helps with recovery as well. And lastly, I've left this to the last part. It is something that I'm passionate about in doing research in, but sad to say that I don't really have a consensus for you as to which strike is the ideal strike for running. There are proponents that say that it doesn't matter. What matters is how hard you strike. There are proponents that say that the rear foot strike is the worst of the three because it puts too much load on the knee. But really, there is no right or wrong answer here. What is important to know is to know what your strike is and to optimize it by not landing hard on it. Suffice to say that you do not want to leave your leg too far behind and put your foot too far in front. Ideally, your foot should land whereabouts your knee is. For example, if you go for a heel strike, you might find yourself overstriding and placing your foot far ahead of your knee, such that you're landing with the brakes on each time, which is very bad for the knee. Similarly, with a forefoot strike, you might be sprinting so hard that you're leaving your foot behind most of the time, and that overstretches your muscles in the knee. So whether you are a heel striker, a midfoot striker, or a forefoot striker, just know that um, what matters is how you strike, and that's what the research shows now. Um, Personally, I have transited from a forefoot strike more towards a midfoot strike. It took me a lot of months to get used to it. It naturally increased my cadence after the transition, but in the initial phases, I find a lot of calf and hamstring issues with the transition. So it takes a while to transition. My hypothesis is that please don't take it because I haven't researched this, but my hypothesis is that if you land on your midfoot, you actually your weight goes through the middle of the knee and therefore balances the load on the knee, and I think that it can probably keep our knee healthier for a longer period of time. So I've come to the end of my presentation, and in summarizing, truly, we have all these factors, as individuals, that may be for or against us. But ultimately, right, it's suboptimal activity that pulls the trigger on this jackpot machine that may give rise to us getting a knee problem. So as long as we keep ourselves moving and we keep our techniques of running varied and appropriate, we reduce the load that pulls the trigger essentially. Right. With that, I end, and I'll be happy to take questions.
Thank you so much, Prof. It was very good sharing. Love the analogies and the pictures. Got worried for a moment when you showed the anatomy picture. Time for answers. But anyway, we've got a few questions. I mean, I've got my questions myself, but we'll touch on the questions first. We have a question on, is there any dietary advice to increase the health of our knees? Any increase in calcium, does that help our knee joints?
It's a good question. So calcium is good for bone health. It is not known particularly to reduce the risk of getting wear and tear, or what we know as osteoarthritis or just arthritis of the knee. Generally, as a general dietary advice for ladies, especially after the age of 50 or after you've hit menopause, your body has a higher risk of losing what we call the strength of your bone. Right, your bone becomes more sponge-like; it gets porous. So to prevent that from happening, if your diet does not consist of milk or green leafy vegetables, it is advisable to take calcium supplements to prevent osteoporosis. But calcium in itself doesn't prevent the knee from wearing out. But there have been some emerging evidence to show that things like natural substances like turmeric um, does reduce inflammatory overload, not just in the knee, but overall in the body. So there are some formulations of glucosamine now which I'm pretty sure someone's going to ask about in a while, so I might as well cover it now, right? So glucosamine was a drug that was promoted in the 80s to the 90s as the magic pill to reverse aging of the knee. It contains the ground substances or the raw materials for cartilage production, and it worked fantastically in the labs on rats. Right, the rat cartilage became thick and strong, and they thought, oh, it's going to work for humans because we share 90% of the genes with the rats. But unfortunately, 10, 20 years later, when we did major studies, it shows that glucosamine is no better than your Panadol in treating pain of the knee. It didn't do anything to the health and the thickness of the cartilage. So today we have people, pharma that have added turmeric to the glucosamine formulation, and some of my patients have reported a better improvement in your pain. So I think it does help with, if you already have knee pain, taking some turmeric pills might actually help, reduce the inflammation in your knee and reduce the pain. But to date, there is no golden or magic pill that you can take to keep the health of the knee going. All the work is, as what I mentioned earlier, in just making sure that your lifestyle factors are modified to ensure that your risk is kept to a minimum of developing knee pain, which means to prevent injury, or if you have an injury, to undergo proper rehab and get a proper treatment for it. And again, going through the 4 elements of your alignment, stability, meniscus, and cartilage. Yeah, hope that answers the question.
On a follow-up to the same question, is there anything about magnesium, omega-3 fatty acids? Is there any part for that to play on?
Yeah, so magnesium not so much, but for omega-3 certainly. So omega-3 has been known to improve cardiovascular and joint health, similar to how turmeric does. It basically suppresses inflammation through fat metabolism pathways. So the knee actually has fats as well. And these fats contain a lot of the nerves, and they nourish the covering of the knee, and therefore omega-3 does help with joint health as well. So if you're going to be taking that supplements such as omega-3, turmeric for general health, you would have a run-off effect on good joint health as well.
All right, thank you. Going on to the next question, we want to know whether the ankle mobility, does that affect our knees in any way?
Yes, absolutely. So actually the entire lower limb functions as one orchestra, right? Starting from your back. How your back posture is affects your position of your hip. Position of the hip affects the position of the ankle. Position of the knee, and the knee turns ankle, and ankle back up again. So, for example, if you are flat-footed, right? If you are flat-footed, you have this problem called overpronation. Some of you have gone to running lab and done your analysis on your running. They may tell you that you're overpronator. And so when you overpronate, what happens is that your knee tries to adapt by rotating itself to accommodate for the overpronation. And similarly, if you have the opposite deformity, is called supination, when your foot goes this way. And when you do that, your knee tries to swing the other way to try to keep balance. And therefore, all this will affect how the ligaments interact with each other, and may put stress on one side of the knee. And that in itself is not a problem. But if you are unfortunate to get an injury, during your running or in the course of your sports, that may be a factor itself. And obviously, if you have very stiff ankles, your running form and the way that you run will be affected, and that may also have an effect on the knee. It is very hard for me to give a very specific example because there are many foot and ankle conditions, positions, and mobility issues. But generally, absolutely yes. How your ankle is will certainly affect the knee problem. In fact, many a times when we see patients coming with knee arthritis, some of them actually have ankle problems that have predisposed them to developing the knee arthritis because of long-term adaptation of the knee to accommodate for the ankle problem. So usually when I see my patients, I do an x-ray of the entire leg, what we call a long leg film, so that I can screen both the hip and the ankle at the same time to make sure that they are not contributing to the knee pain, or the converse is also true, that the knee condition is not starting to affect the hip or the ankle.
All right, thank you. Still touching on the running lab and the shoes, that part. Maybe we have a question on, would choosing the right running shoes with enough cushioning, can that help to prevent or maybe slow down the wear and tear of the knees?
Yeah, so I think it is a factor. So, for example, when we mentioned earlier, taking the example from a person with a foot and ankle problem, for example, if you do have flat feet, right, generally you put a lot of stress in the inner part of your foot, what we call the medial part of the foot, and you can get stress fractures over there. And by overpronating, like I said, you might be wearing out your knee in a very lopsided manner. The forces may not be distributed very well. So you generally, what you need is a high cushion shoe that gives you support to the inner part of the leg to raise up your arch. Hopefully it's still flexible and it can be raised up by the shoe. Therefore, your foot form comes back to normal. And the assumption is that when your foot form is back to normal, you will be loading your knee in a fairly natural way, and therefore your risk shouldn't be any higher than someone with a normal foot and ankle position. Right, so getting the shoe that is fit for your foot is an important aspect of preserving your knee joint. Yes, it is indirect, but it is important.
All right, thanks, Prof.
So where you need cushion and all that would be based on how you strike, how you land, and whether you're an overpronator, oversupinator, and things like that. There are people who love using minimalist shoes or even barefoot running, right? And it doesn't matter what foot strike it is, but it is all about getting accustomed to it. So it is a very developing field, and many researchers are researching about it. We don't have definite answers, unfortunately, at this time. But really, the key thing is to be comfortable. If you feel that you're uncomfortable, then it is good to get it checked at least by a physiotherapist who sees runners regularly, and they may then escalate you to see either a foot and ankle or a knee doctor subsequently if you do have knee or foot and ankle pain.
All right, thanks, Prof. Our next question is, after 45, is it good to run LSD, or is it better to focus more on sprints, shorter distance, for the well-being of our knees?
It's a great question. So I don't think the chronological age is so much an issue. The physiologic age is more important, right? I have seen patients who are 75 who their fitness age is probably 40, and I've seen people who are 35 whose fitness age is probably 60. So it's not so much the chronologic age. With regards to the question, I would like to extend it to the main problems as we age for both men and women. The main issues as we age are that we lose muscle. And this is a hot and growing topic. I don't have enough scope today to cover it, but the term is called sarcopenia, which is in layman term is just known as age-related muscle loss. And if we don't combat this phenomenon of age-related muscle loss, we are going to get into trouble. It's a leading cause for, in fact, what we see known as in-hospital mortality. Of reasons why patients die in the hospital is because they don't have enough muscle mass. So building this muscle mass is important. I don't think if you have no knee pain, no knee issues, I don't think going for LSDs are a problem. But what is important is to ensure that you have good muscle bulk to take you there or to take you through the endurance activity, right? So it is important to have a high protein diet, or rather a well-balanced diet with the emphasis on keeping your protein content up, as well as to do strength training um, at least twice a week. So for strength training, you need to have some resistance to the muscle. This involves either using body resistance workouts, or hitting the gym and using weights to build your muscles. So I think it connects to a broader topic of age-related muscle loss. Therefore, I wouldn't say in a blanket statement that after 45 you shouldn't be doing long distance running. I think you got to ensure that your body is able to continue to withstand it by building the muscles that are needed for it. On the flip side, if you start to develop knee pains, first and foremost, please get it checked. If it doesn't go away on its own by resting and icing it for a couple of weeks, and then you might need to transition to lower impact activity. Aerobic exercise is still important, so it doesn't mean you don't get to work out your heart and lungs. But generally, for my patients with knee problems who had loved running, I have to really try hard to try and transition them to activities like swimming, cycling, elliptical machine, and the cross training machine, which are all low impact on the knee. So the mantra becomes, start low and go slow, right? Build up your aerobic base again from low impact activity. And some of them can subsequently get to very slow jogging eventually, because they just love running. But by and large, the aerobic activity, main aerobic activity, got to be switched.
Thanks, Prof. We've got one question on, if I have wear and tear on my knee and it's shifted my kneecap, am I doomed to not run ever again? Or is there any way, aside from physio, that can help me rebuild the tissue in the knees or even strengthen it?
Okay, so if I hear the question correct, what you've typed, or Kavita, please feel free to just correct me if I'm wrong to assume that you have some wear and tear in your kneecap, which is called the patellofemoral joint at the front of the knee, and perhaps doctor may have showed you the X-ray that shows that the kneecap is tilted to one side. Um, it really depends on whether there is some cartilage left in that joint or not. Sometimes uh, it might be the case, or sometimes it might be that the cartilage has worn out. The good thing about kneecap arthritis is that it often affects only in positions where the kneecap is loaded, which means squatting, climbing, and it often doesn't affect normal walking or even slow jogging. So I wouldn't say that you're doomed to not run ever, but it really depends on the stage of wear and tear that the knee is in. The general rule is that kneecap pain reduces when you strengthen your quadriceps as well as your hip abductors, the huge muscle at the side, the buttock muscles essentially, because that will take away the weight from the kneecap. If your kneecap keeps going to the side, having a knee guard with a circle hole in the center will help to center it. And these are ways to get around kneecap pain. And some therapists even do taping, for example, to keep the kneecap in the center. These are things you can try. And these usually work in the earlier stages of the problem. If you're in the late stage where there's already bone on bone, unfortunately, yes, running will exacerbate and even be very painful. So you may have to either get the treatment for that condition. There are many treatment, again, not within the scope of today's talk, in terms of surgeries, or switch to a low impact activity that doesn't put too much weight on the kneecap, but it still can get your heart rate up and give you the aerobic exercise that you need.
Thank you so much.
No problem.
All right, we've got a more general question on if I'm already taking high blood pressure pills, is it okay to take omega-3?
Yeah, I think it's fine. In fact, unless you're allergic to it, of course. In fact, one of the earliest treatment, even in our hospitals today for patients with high. Okay, so we have this thing called metabolic syndrome, right, in Singapore. Metabolic syndrome is the combination of high blood pressure, diabetes, high cholesterol, and in the Chinese population, they also include gout as part of the metabolic syndrome. So in fact, our cardiologists actually prescribe omega-3 pills to patients with metabolic syndrome because it helps to actually keep your cholesterol profile in check. And there's some very low level evidence to show that omega-3 may increase your good cholesterol, which is your HDL, which protects your heart. So no issues with taking omega-3 pills with high blood pressure medication.
Okay. And maybe touching on just now I mentioned about the 4 different steps and about stability being very important. I think many of our friends here have like ACL injuries, but are still very passionate about football, running. Would you say it's a good idea to stop football and sports maybe and just focus on running, or is it okay to still be playing?
Yeah, so okay, so this is where I'm conflicted, right? Because I'm an avid footballer myself, and then I also wear the cap of a joint preserving surgeon. So I shall throw away my first cap and keep my second cap on as I'm answering this question. So without the ACL, the knee, when it pivots, it moves abnormally. So the ACL doesn't just prevent the knee from going this way, but it also prevents the knee from doing this. So if you go back to football and you keep pivoting, the knee is going to go into abnormal movement, and you can see that without the ACL, this is going to grind away your cartilage. Not just the cartilage, but it's grinding away at the meniscus that may or may not be injured at the time. So what you're putting yourself at risk of is additional injuries in the knee. So you might develop cartilage wear and tear. And as I mentioned, you might feel fine because the earlier stages of cartilage wear do not give symptoms. Or you might tear your meniscus and suddenly after a game of football, you find that the knee is swollen after the next day, or worse still, you may get locking where you find that you can't straighten your knee anymore. And going back to the 4 things we talked about, this is a problem now. Not just you have a ligament problem, you have introduced a meniscus problem in your knee as well, and therefore your COE of the knee is going to be much shorter now, unfortunately, right? So the general answer is that if you have an unstable knee, so the premise is that this is a patient or this is a person with an ACL injury that has instability while playing football, and yet they go and play football. There are some people who compensate very well. It might have been a partial ACL tear where they only injured one part of the ACL and somehow the knee adapted to it and they don't get symptoms when they play football. And this group of patients may be okay to continue doing sports provided they've undergone a fair amount of rehab. Like recently, I saw a national basketball player that came to me with a low-grade ACL tear. She injured maybe 30% of her ACL. She still had 70% of the ACL left. And I wasn't going to do surgery on her and give her a 9-month downtime and take her away from the season. So I told her 6 weeks of rehab, another 6 weeks of return to sports training to strengthen your muscles. And at 3 months, we tested her. Her knee was back at full function, and we sent her back to basketball, right? So it really depends on the extent of the injury, but generally someone who has instability due to the ACL shouldn't be doing pivot sports like football or basketball, but straight line running is absolutely okay. You don't need the ACL to function optimally when you're running in a straight line, because when you're running in a straight line, your knee is in a natural, stable state, and therefore it doesn't pivot. So I think running is good, but anything more than that, trail running, pivoting, sports like football, basketball, probably not a good idea.
Okay, maybe just an extension to that. When some of us have pain on our knees, and because of that, we tell ourselves, okay, I'm going to save myself for that one day of running, maybe once a week. Would you think that's a good way, or is there a way that we can maybe have a progressive? Just now I mentioned about the basketball player. So would you recommend any sort of way that we can try to progressively get back, rather than we come back for one run and then that puts us off for another 2 weeks, then we come back for one run?
Yeah, so I think if you firstly have knee pain that persists on beyond 2 weeks, you should get it professionally assessed, right? Because most soft tissue problems, if they are self-limiting, will start to get better by the 2nd week, and towards the 6th week, it should completely go. So as a general rule of thumb, any pain that doesn't get better on its own after 2 weeks, I think you should get it assessed at least by a primary care physician, your GP or family doctor, and then, if need be, see an orthopedic surgeon or a sports medicine physician. Beyond that, if you know you have an injury and you are recovering from it, then definitely, yes, you need to be put through a proper reconditioning program. You probably need to see at least a therapist to assess the state of your muscles, to look at your hamstring quadriceps strength, and to see whether you need to optimize that. Many a times you talk about a 2:1 ratio. You need your hamstrings to be twice as strong as your quadriceps to do most sports or activities. And that can't be assessed even by me individually. I need to go to a therapist who can put me on a machine to check my 1 rep max and then calculate that for me, right? So that is important. Just skipping a run here and there to take games going, it's a little bit like walking in the dark, with a blindfold, right? You do not know what was going to hit you. So I would caution against that. Building up slowly, like I said, start low, go slow is very important. Yes, your body will decondition, but you've done that before. You've been there before, and slowly but surely you'll get there. I'd rather you save your knee to fight another day than to take momentary pauses only to make that condition over the long period actually get worse and worse. You're just masking yourself by skipping that one run, and then you feel better. You go for another run. You take another few days off, but actually, your general state of the knee is getting worse and worse if you look at the time spectrum.
And thank you so much, Prof. I think we have no other questions. If anyone has any other questions, you can unmute yourself and ask. We can maybe wait for a few seconds.
Hi, Kumaresh and Dr. Guru.
Hey, hi, Guru.
Hey, hi, Doc. So my COE expired a long time ago for both my knees because I tore both my ligaments and meniscus. I went through surgeries on both my knees, and the sad thing is it's torn again. So I'm actually running with torn meniscus and ligament for the past, I think 1 year, one year plus after I joined TMR, and before that I've been everyday doing gym. So the question is, running on a flat ground, on a straight road is no problem for me. The only problem is when I go downslope is even worse. Upslope is partially okay because I slow down my steps and everything. So usually downslope, I will just walk. I don't run or just do very, very slow jog. Thing is, does knee guard help in any way? Because sometimes I become very dependent on a knee guard. Is it just a mental assurance that I need to wear knee guard to run, or sometimes I don't want to wear knee guard so that I can just depend on my muscles, on my thighs and my quads and my glutes to run? So which is which? Because sometimes it just becomes like a mental state. Oh, I need to wear my knee guard. And I think a few friends down here, they are just dependent on the knee guards as well. So what's your advice, Doc?
It's a great question. It is true. A lot of the times the knee guard is a psychological sort of insurance for us. and also a signpost to other people that you have any issue and to not come and run into you, for example, if you're in playing contact sports. So the use of knee guards in running is not at all well established. The reason is knee guards are usually used for, patients with some instability of the kneecap, for example, as I mentioned previously, where the kneecap runs around, and so you wear a knee guard with a circle in the center to keep it in, or for people with swellings of the knee guard compresses the knee and it prevents the swelling from coming into place. But there's also an entity called micro motion of the knee, and this micro instability or micro motion of the knee exists in like cases like yourself, where you have injured your ACL, and I forgot to mention earlier, but your meniscus actually contributes to some stability of the knee as well, because it is like a cup, and when you put the round thing in a cup, it actually prevents toggling of the cup of the round bone, right? So when you have a meniscus tear, that round bone can now do micro pivoting movements. So it is very likely that the knee guard is helping you limit that micro instability, and that's why you actually need it when running. So I think in your case, it is probably not just a psychological assurance, but it actually serves a purpose because of the fact that you have both a ACL injury and a meniscus injury, which means that it may be some instability even when running. Having said that, if I assume that you're not having any pain when you're doing flat run running, it could be possible that you are fortunate enough to have a meniscus tear that has probably not altered the structure or the function of the meniscus. There are many different types of meniscus tears. If the tear is in an area where there is enough blood supply, it might heal on its own. If the tear is actually in the line of the fibers of the meniscus, for example, imagine, if you have a block of wood that is lined in this way and you put a cut that way, you might not be able to see it and it will not affect the structure of the wood. But if you cut the wood against the grain, that is going to alter the structure of the wood and it will bend in shape. The meniscus is like that. So if your tear is in line of the meniscus is going to retain its structure, and therefore you may not get much symptoms, or the tear might even heal. But if your tear is in the opposite direction, it's like a polo mint, the polo sweet. If it breaks right through the middle, it's going to lose its structure completely. So that happens to the meniscus. So it is possible that you are lucky to have a meniscus tear that is probably okay for you to run on flat ground. And that could be the reason why it may not be the same for someone else with the same injuries as you, but different type of a tear. I hope that answers your questions, Guru.
Yeah, thanks, Doc. Thanks. Thank you so much.
All right. Does anyone else? Oh, okay. We have a couple more questions now. You mentioned that taking shorter strides and improving cadence earlier. I think for cadence, you mentioned around about 160 to 190 as the range that one should ideally look to hit. How does one improve running cadence?
Yeah, so it is okay. So it is very difficult because when you're used to your stride length and then suddenly to increase your cadence. So it is a formula, right? Your cadence is essentially the number of steps you take per minute, and your number of steps is dependent on your stride length, and that in terms is determined by your the length of your legs essentially, and how you run. So the way I increased cadence was to actually transition a little bit towards landing on my midfoot. So when you land on your midfoot, you don't have that toe off that you normally get when you run on your forefoot. So when you run on the forefoot, there's a lot of momentum, right? When you land on the forefoot, immediately you bend your foot and then the next foot goes and next foot goes. So you naturally take a bit longer strides. So for me personally, the trick to increasing my stride length was to consciously try not to land on the balls of my feet, but just behind the balls of my feet, in between the middle of the foot and the front of the foot. So when you do that, you don't have that natural momentum to take a long stride. So you will end up taking shorter strides. It's very unnatural when you first start, but you can try, and that's how I transition from a step rate from 150 towards 170 by transitioning. But as I mentioned, as you transition, just do stretch out your hamstrings and your calf muscles a bit more, because they will tend to take the hit if you don't. Yep, I see one more question on consumption of protein bars and whey-based protein and how effective they are. Yeah, I think not just in promoting knee healing and recovery, but general, like I said, uh, to get general recovery as well as to prevent sarcopenia, as I mentioned. mentioned, I think taking protein. So if you are someone who doesn't include much protein in your diet, then certainly supplementing it with protein bars and protein powder will help in general recovery, and definitely the muscles around the knee as well after a long hard run. I started tracking my protein intake about a year and a half ago, and I realized that I was falling way below the requirements for someone my age. And so I supplemented it by taking a smoothie in the day where I included whey-based protein to give myself an additional 20 grams or 30 grams of protein to add to my total protein intake for the day. So you should be hitting about 60 to 100 grams of protein a day. Generally speaking, if you are very active, you might need the top end. If you're not very active, probably 60, 75 is sufficient.
Okay,
Yep. So about knee compression, and yep, yeah, it's completely fine. You know, unless you have a knee problem like what Guru mentioned, you don't need a knee guard. So if your knees are healthy, you don't feel anything, you can run without any knee compression. That's okay. If you have some knee problems, then it depends on what that problem is and whether you need anything external to stabilize the knee. So if you don't get knee swellings or you don't get knee pains frequently, running without a knee compression or a knee guard is all right. You know, all those 2XU compressions, stuff that we wear, no real strong evidence, but basically what they do is they keep your muscles warm and give them a bit more endurance, especially if you're doing longer runs, essentially.
Okay, thanks, Prof. Maybe we can wait just for another 10 seconds, see if anyone else
Sure.
has any question. Okay, if not, Prof, thank you so much for sharing with us. It was really insightful and very informative. I'm sure I think we have all learned a lot, and I think hopefully going forward, we don't see as many of us having too many knee issues. But if we do, oh, there's one more question, sorry. Does any external creams help for the knees? Any to recommend?
Yep. So I think maybe, yeah, those who want to leave, please feel free to leave. I'll just take this question for Dharma. Yeah, so magnesium, not really. So there are many types of creams out there. So if you're treating pain, then obviously those pain relieving creams certainly have an effect. Fastum gel, your methyl salicylic acid, which is like your menthol creams, all these definitely help. Fandi Ahmad was promoting the glucosamine cream. Not much evidence for that, unfortunately, because glucosamine, even in the tablet form, doesn't help. So I don't see how the cream form will help. But certainly those pain relieving creams certainly have a role to play. Magnesium, I must acknowledge that I have not heard of magnesium creams just yet. What I can do is I can go and do a bit of digging up in the medical literature and get back to you on that, Dharma. Right, great.
Thank you so much, Prof. And everyone else. Let's all have a good end to the week. I hope everyone continues to stay fit. And if we do have any issues, I'm sure many of us will be looking out for you, Prof.
No problem. I hope no one needs to, but yes, I'm always here. Thank you so much. Thanks, guys. See you. Bye-bye.
Thank you very much.